When we talk about acute coronary syndrome, we are looking at heart attacks, unstable angina, and heart attacks. We have two types of heart attacks. One is ST segment elevation heart attack. And when you look at the ECG, the ST segment is elevated, and we treat those patients in a certain manner. Those patients need to be rushed to the cath lab in a timely fashion because we have to open the blood vessels. If we don't open the blood vessel, then those patients will continue to get heart muscle damage, and as a result, they will develop heart failure, and it will affect their prognosis. So that's what we call STEMI, ST segment elevation MI. It is a form of acute coronary syndrome. What we're going to look at today is the non-ST segment elevation heart attack or acute coronary syndrome. In the United States, the non-ST segment elevation acute coronary syndrome affects more than 625,000 patients annually. Okay, so majority of the patients who presents with acute coronary syndrome are gonna present with non-ST segment elevation acute coronary syndrome. So, the two types of heart attacks, the STEMI and the non-STEMI, majority of the patients are going to present with the non-STEMI. When someone presents, usually in the emergency room, with an acute coronary syndrome, you have to do your history, do your ECG, and then we talk about biomarkers. You have to do these, but in addition to doing the history and the physical and the investigation, you have to quickly assess the patient and see what you're going to do with them. And we're going to talk about an ischemic guided strategy versus an invasive strategy. So when we talk about an ischemic guided strategy for these patients, we're going to basically treat them with the best medicines, the medicines that have been shown to be effective in these patients. We talk about guideline directed medical therapy. There are some of these patients, however, when they present, they are really sick, and if we don't do an invasive strategy, that is cardiac catheterization and revascularization with stents, they will not do very well. So we have to know how to approach these patients, and we usually do that when the patient presents in the emergency room. So the take-home message is that majority of your patients are going to present with non-STEMI, non-ST segment elevation acute coronary syndrome. When we talk about a heart attack is due to decreased blood flow in the blood vessel around the heart, and you can have a partial occlusion of the blood vessel, or you can have a complete occlusion of the blood vessel. So it's a spectrum. So it's a spectrum of myocardial ischemia and or infarction. So when we say something is infarcted, it dies. Okay, so the heart muscle dies, and this cartoon sort of depicts what happens. So your normal blood vessel, you can see, you have the intima. So remember, it's an artery. So you have the intima, the media, and the adventitia, and the normal blood vessel, the normal artery, the lumen is smooth and looks pretty good. But you can have these fibrous plaque or fatty streaks developing. we have oxidized LDL. So when you need to know the risk factors for acute coronary syndrome. And the risk factors are dyslipidemia or hyperlipidemia, hypertension, diabetes mellitus, smoking, and family history. So those are the major risk factors. There are some other minor risk factors. So dyslipidemia or hyperlipidemia, where you have an elevated LDL, and not only elevated LDL, but the LDL is oxidized, and then it's phagocytosed in the the arterial wall. So, and then these fatty plaques get a little bit larger, and then you have a well-formed plaque, repeated phagocytosis, and other cells crowd the area. And then these plaques, if the cap of the plaque is very thin, or if the plaque contains a high lipid content, we talk about a fatty plaque. These plaques are prone to rupture, and when they rupture, they cause blood to clot on top of the plaque, and you can have partial or complete occlusion of the blood vessel. So this is a little larger representation. So another cartoon. So again, a nice smooth artery, and again you have the intima, the media, and the adventitious, the outer layer. Okay. So most of our fatty streaks is in the media, where you have the muscles. So you have the phagocytosis of the oxidized LDL. You get the fatty streaks, and then the fatty streaks builds up, and you have the cap, the fibrous cap. If the fibrous cap is very thin, and the lipid content is high inside the plaque, and it's prone to rupture. And again, when it ruptures, then you have blood clot on top of the plaque, and you can get complete or partial occlusion. And so when someone presents with an acute coronary syndrome, and we're looking at just non-ST segment elevation, acute coronary syndrome, we have to come up with a diagnosis real quick. And how we do that, we're going to take a history, a focus history, and we look at the ECG. The ECG will allow us to distinguish between a non-ST segment elevation heart attack or acute coronary syndrome and an ST segment elevation acute coronary syndrome. They're treated different. They're treated completely different. So if it's a ST segment acute coronary syndrome, these patients have to rush to the cath lab as soon as possible. If it's a non-ST segment elevation, then in that category we have what you call unstable angina. These are patients who are unstable. They're having more frequent chest pains. The chest pain is lasting longer, telling you that the myocardium is in jeopardy. And then you have the true non-STEMI, and the non-STEMI is a heart attack. So don't mistake. It's a heart attack, but it's different from the ST segment elevation heart attack. And you need, after the ECG, after you do your ECG or EKG, you need biomarkers. And the biomarkers that we're talking about is your troponin. We used to have a whole gross of biomarkers, but the ones that are recommended at present is just your troponin. And then you come up to your final diagnosis, and then how you're going to treat the patients. So the initial assessment and evaluation of these patients. So the patient would usually present to the ED, or if they present to the doctor's office, then if you suspect acute coronary syndrome, you should risk stratify the patient. And what we mean by that is, okay, you take a history, patient is having chest pains, and you do your ECG, and the ECG may have some changes, not a STEMI. We're not dealing with STEMI in this lecture. So they have some changes, and the cardiac biomarkers are elevated. You have to risk stratify these patients. Basically, what you're doing at an early stage, you're gonna determine the likelihood of these patients not doing well. And of course, death is among not doing well. So patient comes to the ED, you do all your stuff, you have to risk stratify them, okay? Basically, you're gonna look at the mortality and the recurrent heart attack in some of these patients. So some of the high risk features of these patients is if they continue to have chest pain, because some patients will come and they will have, one-time chest pain, and that is it. Some patients will continue to have recurrent chest pain and shortness of breath. They may pass out, they may have palpitations. So if these patients are seen in the doctor's office, then they need to be rushed to the ED, the emergency department, and you need to get the emergency medical service to take them there. You shouldn't drive them to the ED. Okay, so you call the ambulance, and because this is telling you that it's an emergency. So this is if they present in the doctor's office. A lot of these patients are going to go to the ED, the emergency department, directly. So if you see the patient in the doctor's office and the symptoms are not as dramatic, then you have a little bit of time to, they can probably use their private vehicle to get to the ED, or you can even refer them to a chest pain center. But when we talk about risk stratifying these patients present to the emergency room, classic chest pain, the ECG may have some STT changes, and the biomarkers are elevated, telling you that the patient is having a non-STEMI acute coronary syndrome. We have a risk scoring system we call the TIMI, and you should apply this from the ED. Okay, what the TIMI score does, it looks at all-cause mortality. That is, is the patient going to die? New or recurrent heart attack, if the patient going to have recurrent heart attack, or they're going to have severe ischemia requiring a stent or bypass surgery through the next 14 days. Okay, so you're going to do these risk analysis in the ED. If they have a 0 to 1 risk, then the percent of these things happening is about 4.7%. If they have a score of 2, then it's about 8.3% of these things happening in 14 days. 3 points, then 13.2, 4 points, 19.9, and 5 point, 25.2, 6 points. So these are the things that determine the score. So we look at 7 variables in the TIMI score, and each of the variable will get up 1 point. So if the patient is 65 years of age or older, they get 1 point. If they have 3 or more risk factors for coronary artery disease, they get 1 point. So remember, the major risk factors for coronary artery disease: hypertension, diabetes, cigarette smoking, family history, and dyslipidemia. So those are the 7 variables you're going to look at. And again, so greater than 65, 1 point. 3 or more risk factor, 1 point. If the patient had a prior catheterization, which show that they have one of the vessels have more than or equal to 50% stenosis, blockage, then they get 1 point. If the ECG that you do in the emergency department shows that there is some ST deviation, it might be a little bit of ST segment depression, then they get 1 point. If the patient had greater than or 2 anginal events in the last 24 hours, so there are 2 episodes of chest pain, which suggests it's angina, then they get 1 point for that. If they use aspirin in the prior 7 days, then they get 1 point. So these are the variables. Each of the variable get 1 point. And again, you can see the score number to the risk of these adverse events occurring. Again, so you should walk around with the risk score until you sort of memorize it. But that tells you how aggressive you need to be, because if your patient have a score of 6 to 7, the percentage of these adverse events occurring is pretty close to the 41%. So that's very significant. Okay, so patient presents with chest pain suggestive of acute coronary syndrome, and you do an ECG. There may be some ST segment deviation. Patient may have some risk factors, and you're gonna get your biomarkers as soon as possible. And again, the biomarker we're talking about is your troponin, your troponins. So when the patient gets to the ED, you want to get an ECG, a 12-lead ECG, within 10 minutes of arrival. And this is very important in the United States, because if you don't follow these guidelines, you're liable. Say the patient comes to the ED with chest pain and you do the first ECG in 30 minutes, you're liable. So you need to know the guidelines and you need to follow them closely. So a 12-lead ECG within 10 minutes of arrival to the ED. So anything in green is good. Well, not only good, but this is what you have to do. There's no leeway, if it's not done, and everything is documented. So you can't say that, yes, I did it in 5 minutes, because everything is documented. And if you don't do it, then the system will not record it. Okay. So if the first ECG is non-diagnostic, normal, within 15 to 30 minutes, you have to do another ECG. So we usually talk about just repeated ECG. What I do is, I don't sit down and time it. Within every 5 to 10 minutes, I have to see, what the ECG is showing, especially if the patient continues to have symptoms. If the patient continues to have chest pain and shortness of breath, every few minutes, because it's an evolutionary process, and the first couple ECG may be normal, but the next few is going to be normal. So you need to do your ECGs. And then the biomarkers. In today's climate, the only biomarker you need to do is your troponin. A few years ago, we were doing all sort of stuff, myoglobin, we're doing, CPK and stuff like that. This is the only thing you need to do. So if the patient comes in and they have symptoms suggestive of acute coronary syndrome, you're going to do your troponin as soon as possible. You want to do your troponin every 3 to 6 hours, even if the first one is positive, especially if the first one is negative. So 3 to 6 hours, different institutions have different protocols, but you want to do it every 3 to 6 hours. and then you want to use your risk scoring system. So now is the time for you to quickly use your TIMIS score to see what type of risk you're dealing with, because the high risk patient is usually treated a little bit different. And remember, we talk about the ischemic guided approach as opposed to an invasive guided approach. So, once it's colored, you should do it, or yeah, I mean, it's sort of iffy. Um, you know, there are other risk scoring system, the GRACE. So people who do exam needs to know a little bit about the GRACE. The thing about the GRACE scoring system, you need a calculator to do that. So it's best to just Google it and put the information in, and it will spit out a score and the risk associated with that score. So this is saying that if the initial 12 EKGs don't show anything and the patient continue to have chest pain and shortness of breath, you can do unconventional ECGs that you can do V7 through V9. You can also do continuous 12 lead ECG, and you can do BNP. It's not, I mean, usually, especially if the patient has some shortness of breath, we routinely do BNP. So for those of you who are not familiar with BNP, it's brain natriuretic peptide, or you can do NT-proBNP. So these are compounds that are increased when there is increased stretch in the atria. So it's good to diagnose heart failure. There are other things that can cause elevation of BNP, however, but just imagine if these patients are having acute coronary syndrome and they present also with heart failure, then the prognosis is not going to be too good. So you can do BNP or NT-proBNP. So this is a GRACE scoring system. With the GRACE scoring system, we have the age, the heart rate, blood pressure, systolic blood pressure, the creatinine, whether the patient is in heart failure, yes or no. So you just plug these information in the GRACE calculator, and it will give you a score. So you don't make any sense you memorize that. So the one that you definitely should do is the TIMIS score. And again, these are the variables we're talking about. Each get 1 point. A low risk individual will have 0 to 2 points, intermediate risk 3 to 4 points, and then a high risk individual will have 5 to 7 points. And we show you the percentage of adverse events that is associated with the points. Now with the GRACE score, the scoring system is a little bit different, but the calculator will do the scoring system for you. So we talk about a low risk individual with a score of 1 to 88, intermediate risk individual 89 to 118, and high risk someone with a score of greater than 119. So you need to be familiar with the scoring system because you have to risk stratify these patients. This is just the GRACE looking at the different things. So again, ECG as soon as possible, within 10 minutes. Someone who presents with chest pain, don't triage them with your general ED patient. They have to be separated. Because if you don't do the right thing, your institution will be sued. So ECG within 10 minutes of arrival. If you want to repeat, if the ECG is normal, 15 to 30 minutes, I would just go ahead and say once a patient presents with acute coronary syndrome, you need multiple ECGs, to not get into trouble. Every 10 minutes you should be doing an ECG, because this is an evolutionary process and you don't want to be caught flat-footed. Where you run into major problem is if the patient presents with chest pain and all the risk factors and the first ECG is normal and you don't do another ECG, and then 30 minutes you decide to do a ECG and it's really a STEMI, you have no leg to stand on, you can be sued big time. So because a STEMI patient need to be taken to the cath lab as soon as possible. Time is of the essence. You have 90 minutes from the patient hit the ED to open that blood vessel. And if you waste 30, 40 minutes not doing the ECG, not finding out that it's a STEMI, you lose that time. And then to get them to the cath lab, if anything happens to that patient, when they check the timeline, you'll be outside of the recommended time and you'll be liable. Okay. So again, same thing as the ECG. You want to do serial cardiac biomarkers, and it's a troponin IRT, and you get your initial one as soon as the patient gets to the ED, and every 3 to 6 hours thereafter. And even though some people say you get three troponin eyes, but of course if it's going up, you want to still get more, because you want to see where it's peaked out, because the level of the troponin also tells you, give you an indication of the extent of the infarct. So you want to do more. And again, we talk about the risk stratification, because even though we take STEMI to the cath lab and revascularize those patients as soon as possible, there are some non-STEMI acute coronary syndrome that we have to do the same. So you have to do your risk calculation and see if the patient is high risk. If the patient is unstable, the patient continues to have chest pain, hemodynamically unstable, then you have to think. So the only biomarker that we use is the troponin, and we use the BNP, because the BNP gives you some type of it helps you with prognostic in prognosis. It will tell you how well the patient's going to do, because if these patients start having heart failure, then it's a significant heart attack. Okay. So the importance of this slide is that we don't do CKMB and we don't do myoglobin anymore. We don't do that. What you need is your troponin INT, and as soon as they hit the ED, you get one, and then 3 to 6 hours thereafter. If it's going up, you still get repeated troponin. If it's going down, then you can just stop right there. Okay, so this is just an introduction to non-ST elevation acute coronary syndrome. On Thursday, we will go into depth how the patient is managed in the emergency department, and then how the patient is managed in the hospital, and then what you need to do when you send the patient home. All right, so we're gonna stop here, and on Thursday we'll finish up. Okay, all right.